It's 2 o'clock on the afternoon of Wednesday, the 7th of September, and you're all very welcome to the Health and Wellbeing Board. Pete, are we live and broadcasting to the world?
Are we broadcast on YouTube?
Sorry folks, can I just check, is a YouTube broadcast started? Thank you. Yep, we're live, Chair.
We are global. Okay, thanks very much. It seems like a long time since we've been here, and we've managed to survive heat waves and wildfires and droughts and a variety of things since we've last been here. We've just had a new Prime Minister, had a new Secretary of State for Health, Therese Coffey, and you just wouldn't want to have that in tray. It's going to be an enormous challenge. But new changes bring new optimism, and I'm sure we're all here today full of optimism of things to come. We've almost survived, although we're just in the middle of a utility crisis, and it was just out of curiosity that today I was looking through one of our magazines, and the University of Nottingham Queen's Medical Centre has put aside £27 million to pay the electricity bill for 22 to 23. An increase of 213%. So if we thought that the NHS was cash-strapped previously, just gives you an idea of the staggering areas in which money is going to disappear in the next year or two. I'm going to say quickly, if we could look at the minutes of the last meeting, which are pages 3 to 12. These are for noting only, and I'll just go through the pages 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. And those are for noting only as opposed to for comment. I'm going to go over to Pete Barker to ask if we have any apologies for absence. Pete, any apologies?
Thank you, Chair. We have apologies from Councillor Shaw, and Councillor Camilleri replaces Councillor Anderson. Councillor Henry replaces Councillor Caroline Henry, replaces Sharon Cadell, and Councillor Richardson replaces Councillor Bradshaw. Thank you.
Thank you. Does anybody here present have any disclosable pecuniary or non-pecuniary private interests? If so, now is the time to declare them. Tillum. Okay, we'll only say good things about it, Tillum. Anybody else got anything to say? No, if you think of something during the meeting, feel free to bring it forward. Thank you. And we're going to move swiftly on. We've got a busy agenda this afternoon. We've got 7 or 8 items. I'm going to still aim to be finished for 4 o'clock. Come on, John. We've done it before. So we're going to give maybe 20 minutes for each item. With 6 items, that's 2 hours. It can be done. It can be done. So the Chair's report, well, this is the thing that we can start with, and it generally looks nationally and locally to see what's happening. I was led to the fact that this Friday is actually World Suicide Prevention Day, and I thought because of the amount of mental health that's within that, it was just worth mentioning it because it's all about awareness. It's all about making people feel free to talk about mental health. It's all about making people being able to say when they've got problems, and just as importantly, to be able to access help and support for that. In the UK, 67,000 people commit suicide every year, and that equates to 1 every 90 minutes. So during the 2 hours of this afternoon, 1 person in the UK will commit suicide. In terms of the people that are involved, 75% of them are males, and the vast majority under 50, and it's the biggest killer of men under 50. So we really want to promote at every opportunity about being vocal about mental health. There is the mental health crisis line, which is a 24-hour line, and people can call it at any time of the day, 0808 1963 779, and I rang it, tested that it was there, and it is actually there as of today, which was quite nice to know. For those of us in the medical profession, it was quite sobering to read about the GP who died in the last week, called Gail Milligan, who was just a 47-year-old GP who, through the pressure of COVID and the sheer inundation of the pressure of general practice and in life in the NHS in general, took herself into the woods and apparently committed suicide. It just seemed reasonable that this is the type of pressure that is out there at the moment and that we're trying to deal with and to cope with. In terms of that, I was drawn to item number 8 on page 14, and that is our Not Alone website. The Not Alone website is an award-winning website. This provides information for young people seeking mental health support and advice, and it got the Technological Award for Local Government Judges as the winner, looking at true collaboration and partnership across a wide range of stakeholders. And we have indeed had the people who came up with the idea here in previous meetings and had presentations on it. And again, I was on the website today looking at it, and it's just improved more and more, easy accessible, plenty of good videos that draw you in, a huge amount of areas covering most of the detail, and I believe we're going to have one for adults and carers, etc., being added in the near future. So I was drawn to that. Other than that, there's quite a number of national mental health papers on 13, 14 and 15. There's the usual tobacco at 16. It wasn't long ago that we had our Make Nottingham Smoke-Free workshop, getting the population of Nottingham down to a smoking prevalence of less than 5%. We pointed out that in Rushcliffe it's 5.9%, so there are parts of the county that are almost smoke-free already. We'll be reporting formally on that workshop in the next meeting, and it was a fantastic workshop. I really thought it went down very well. I was drawn to item 17, which is the new world in which we live. We live in a world where children are growing up and have challenges that probably didn't exist when I was a child. They're largely from families which cohabit rather than marry. They live in this digital world where you never see them without some iPad or some phone or something in their hands, which I find, although communicating with people is in a way exceptionally self-isolating. More mothers are working, and yet mothers are still in charge of all of the childcare, and I presume the pressure on them with the utility crisis, etc., is only going to grow, and young children are at the greatest risk of inequality and poverty going forward. It's startling, the challenge of bringing up family in this world that we live in. Homelessness is there at number 19. The next workshop is on homelessness, and it's not the homelessness of the person that's been lying in the street for the last 20, 30, 40 years. It's going to be the new homeless who can't afford the bills, who can't afford the rent, who can't afford to stay in their own houses, and boroughs are being inundated with calls to help rehouse people who are truly struggling, and that's a struggle that will continue to go forward. So that's as much as I've got to say locally and nationally about that, and I'm going to move quickly onwards to the first paper. Oh, Councillor Wilmot.
Thank you very much, Chairman. Just a few bits and bobs from the report. I welcome, in fact, the award to the Not Alone website for their website. But what I'm asking for is more information to be released to the media and social media on how to access the service. It's a good service, but it seems to be that it's not got around to the people necessarily, to the people who need the help. So I just wondered if we could make sure that it's put forward, you know, and introduce more, even on television, if we can get it on. You know, yes. I understand that yes. if we publicise it too much, there'll be too many people want the service. I understand, but that's a good thing. That means that we are getting hold of the necessary who need the help.
Thank you, John. I think sort of perversely the fact that older people may not be as aware of it is actually a mark of success, in that it is going out into all the schools, it is going out into all the youth clubs, it is going out towards the young people that are out there with it. And I suspect if you ask any young people out there, have they heard about it? I think
the other issue, of course, Chair, was the fact that we used to have an elderly meeting, you know, with all the elderly residents and yes. so forth, which after the pandemic has never restarted. Yes. That's another issue that needs to be, you know, sorted out, because we've got a lot of elderly, and there's more and more people getting elderly, and you know, they need some help.
There's no doubt that social isolation, the elderliness, is one of the many challenges that we have going forward, and it is high on everybody's priority. Thank you for that, John. Nottingham Combating Substance Misuse Partnership. This is item number 5. Phenomenally interesting. Sorry, did I miss something? Yeah. Oh, sorry, Sheila. Before I move on,
we're going to speak on number 24.
By all means, yes.
He had a consultant until he was 11, and then consultant left, and his care worker wasn't same way as him. But I'm glad to see that this is in here about getting right care for young people with autism and mental health needs. And if there's anything I can do to help, to spread, you know, good news, I'll be there.
Thank you, Councillor Place. I think that the priority for improving health inequalities is right at the front of our thinking, particularly people with learning disabilities who often have the most problems which go unnoticed, and it certainly is a priority and an important area to look at. Equally well, the transition from childhood to adulthood and the continuity of that care is exceptionally important, so people don't slip through the net. Thank you, Councillor Place. I'm going to move on now to item number 5. It's fantastically interesting that we have a government which has just launched December 2021 a From Harm to Help £3 billion initiative, which is coming right down to Nottinghamshire, funding the new partnership agreement. There are significant changes with regards to that, significant targets. This is just the very start of it. This is the introduction of the partnership, and then we have to choose a responsible officer, and then we have to move forward as Nottinghamshire in order to be part of that 10-year government harm to help strategy. I'm very excited about it, but I'm going to pass over to somebody equally excited, Councillor Jonathan Gribben, Director of Public Health.
Thank you, Chair, and good afternoon, everyone. I suppose one of the reasons we should all be excited and enthused about this is that substance misuse is an enormous agenda, isn't it? I think we probably know that for ourselves in any case. It's one of our priorities within our joint health and wellbeing strategy that we agreed just a few months ago. And that really is because of the burden of ill health associated in particular with dependency. You'll see from the next paper that we come to just a little bit later on in the meeting, that if we think about in Nottinghamshire the years of life that are lost to death or to disability, that 1 in 10 of those years is lost due to, well, most of it to alcohol actually, and some of it to drugs as well. And so you can see that actually the opportunity to tackle this represents an enormous opportunity for us to improve population health. If we're thinking about health and well-being in slightly broader terms, of course, alcohol and substance misuse have implications that go much wider than that, have implications for education for households around domestic abuse and so on and so forth. And as a result of that, we're really pleased within Nottinghamshire County Council to work with a wide range of partners, many of you represented here. So we're really pleased to work closely with Commissioner Henry, with our NHS colleagues and with others around this agenda. As John said, I'm going to pass now to Sue, who will focus us a little bit on some changing arrangements coming up. And then in the paper that follows, we're going to have an opportunity to look at some of the key health and well-being needs across Nottinghamshire County that new partnership will be focusing on. So, Chair, if I may, I'll pass over to Sue Foley. Thank you.
Thank you very much, Jonathan, and thank you for having me on the board this afternoon. So I'll just go through, giving a brief presentation about the key points of the paper, if my thing will go forward. So just talking about the requirements. So as Chair said, the strategy From Harm to Hope was published in December 2021. It had 3 main priorities that it was going to look at. It was about breaking drug supply chains. It was about delivering a world-class treatment and recovery service, and also addressing generational and familial perpetual use of drugs and substance misuse in families and in communities. So those were the 3 main priorities, but as the paper says, we've added a local priority for ourselves, as Jonathan said, which is looking at those health inequalities and wider determinants that really do have an influence on our substance misuse in Nottinghamshire. So hence that's why we're adding that as a local priority, which in turn will help us meet the 3 priorities of the From Harm to Hope strategy. So local guidance on delivering the strategy was published in June, and one of the requirements was to set up this multi-agency partnership that we're in the process of doing at the moment. So the purpose of the partnership is to have this multi-agency forum for mainly implementing the From Harm to Hope strategy locally, and we have, Jonathan said, lots of members from a wider number of organisations, and also to make the point that this will include service users as well, because we do need that lived experience voice, that those people who actually have been either through the service system or have actually had family members or friends who have been substance misusers, because that's a really important aspect of what the forum is about. So a process of that will be introduced. This will replace the current substance misuse strategy group that has been in place for quite a few years now. The difference between the new partnership and the old strategy group is mainly 2 things. One is that the new partnership will mainly focus on delivering the From Harm to Hope strategy locally, those 3 priorities, and that's 1 local priority that we have, including that alcohol misuse emphasis we're going to have as well. But the other thing is that the membership is, in terms of organisations, it's quite similar. It is that we have Police and Crime Commissioner Office representation. We used to have Nottinghamshire Police, the old CCGs, probation, trading standards. So the organisations are the same, but the new partnership really emphasises the influence that these members can have. So we may have had the Nottinghamshire Police involved in the old strategy group, but for the new partnership, the emphasis, they want the Chief Constable represented, or at least deputy of them. For the CCGs, well, they're now the Integrated Care Board, but they want a director of the Integrated Care Board as a member of the partnership. So you can see that the partnership is the emphasis is to have more clout, more influence at a strategic level to really get those actions and address those needs that the JSNA is going to talk about later on. So that's the two main differences. And yeah, the members that we've got already involved, I think will really be able to achieve that for the partnership and for the strategy. In terms of other purposes, we're looking as well at the impacts of alcohol misuse. The strategy has a bit more of an emphasis on drugs, but we know in Nottinghamshire that alcohol misuse is a really high need there. And obviously, as Jonathan said, it is a priority for the joint health and wellbeing strategy for Nottinghamshire. And it's health inequalities emphasis for the Integrated Care Board and partnership as well. And also we've got that fourth priority, looking at those the bigger picture around those health inequalities, wider determinants of why people misuse some substances in the first place, but then also what is that impact of that substance misuse on the wider family, wider community as well. So with that in mind, the partnership is going to link to groups such as the Domestic Abuse Partnership Board that was set up fairly recently, and also it will report to the Safer Knots Board as well, bringing in that criminal justice and police and probation aspect, and it will be reporting, of course, to the Health and Wellbeing Board. So we're looking for the partnership to really have that influence on substance misuse in Nottinghamshire, but also to have that wider links to those wider determinants for that fourth priority. So in terms of where we're at in development, you have the table there in the paper. So this just shows where we're at the moment. We have the membership of the partnership complete at the moment. The footprint for the partnership is going to be Nottinghamshire County, but we will have close links, obviously, with the Nottinghamshire City partnership, which is being stepped up at the moment as well. Obviously, there are links across the whole county for substance misuse, and we'll make sure that those links are very close. There's something called the Senior Responsible Officer, who basically is the conduit for the partnership. He or she will make sure that the influence of the partnership is at its height and the work is actually being done. So at the moment, in the interim, it is Jonathan, the Director of Public Health, but this is something that's going to be looked at by the partnership in the coming months, just to see who that can be on a more permanent basis. And those who are the partnership lead, public involvement lead, and data and digital lead, this is the team underneath the SRO who also make sure that the cogs of the partnership run smoothly. As it says, that's an interim group at the moment, and that'll be firmed up and confirmed as we go along with the partnership. What's still to come and we need to do is we do need to agree those terms of reference and the governance structure. The first meeting it looks like it's going to be the 5th of October. So the formal agreement of those terms and references and the governance is going to be had at that 5th of October meeting. There is a health needs assessment being conducted at the moment that's due by November, and my team, led by Tristan and Sarah Quilty, is developing that along with our partners as well. You may question, well, haven't we just done one? We've got a joint strategic needs assessment coming up now. Isn't that it? But it's slightly different. The joint strategic needs assessment looks at substance misuse across the whole population and those needs. But the health needs assessment will specifically look at these ambitions of the strategy and those real specifics that we need to look at in order to develop a local delivery plan. So some aspects of the JSNA will, of course, inform the health needs assessment, but there's just a few other aspects that are pertinent to the health needs assessment that need to be looked at. And we are developing that local strategy delivery plan. There is a workshop on Monday for the criminal justice partners in this, and that's been arranged with us and the Nottinghamshire City. So that's already in plan to have a look at some actions we can take for the criminal justice element of the strategy. Local performance network needs to be developed, but there is a local outcomes framework that we need to report on, so that's going to be developed as well. And of course, we've got to start reporting on our progress in April too. So things are in hand in terms of development of what the partnership needs to do, but of course there's still a lot of work to be done in between now and April with our first report. So just to summarise, the partnership is required by the local guidance to locally implement the From Harm to Hope strategy. It is multi-agency, but like I said, the requirements in terms of who actually is on the membership board is actually at a much higher and more strategic level, and so it should have that real influence and real punch to deliver the objectives of the strategy, and that will include our fourth priority around those wider determinants and health inequalities, and also alcohol misuse as a priority for the joint health and wellbeing strategy. And our progress on development and delivery is on course, and we will of course give regular updates to the Health and Wellbeing Board as we go along. So that's me done. Please, any questions for myself or my team?
Thank you, Sue. I think in terms of priorities, the breaking the drug chains, etc., is pretty well national. That'll be some form of national approach to that, and the delivering world-class treatment will be through our own CGL Change, Grow, Live, and I believe there's an extra £5.6 million over the next 3 years, which will go into employing 15 extra new posts for 2022-2023, clinical staff and psychologists, and the item achieving a generational shift will probably again be a more national type of approach to things. I was going to actually sort of look when we're thinking nationally. This is £3 billion. This is a 10-year Harm to Hope project, and we have the benefit of the Police and Crime Commissioner here, Caroline Henry. I'm going to go over to you, Caroline, and ask, from the police's point of view, what are your thoughts and your visions?
Thank you very much, Chair. I'm really excited about this. I think it's a massive opportunity, but we need to work together. One thing that hasn't been spoken about so much is the preventative work, which I'm really passionate about too. I feel like a lot of the money seems to be going through public health rather than coming to the police, and obviously, you know, we need to be testing on arrest, alcohol tags, drug. You know, there's opportunities here, but we must work together on it.
Thank you.
And one more thing, I just noticed you mentioned you'd got a criminal justice meeting on Monday. Obviously, I've convened a local criminal justice assurance board, and I don't think I was aware of the meeting on Monday, because again, I'd like to be joined in.
Thank you, Caroline. I think that this is right up that street of looking at drugs and alcohol as a public health issue. And I know you share the views on that. I take the point that you made about prevention, and it's quite an interesting one, that could either Jonathan or Sue ask where the elements of prevention exist within this? Who wants to take that?
I'll let Sue pick that up, but I'd like to speak, if I may, to a couple of the other points.
Yeah,
Thanks.
no problem. Sue, prevention.
Okay, yeah, no, absolutely. Sorry, I'm a bit echoey. It's a bit strange. Yes, yeah, I absolutely agree with that. And although quite a few aspects are being looked at nationally, I think the intergenerational generational shift, that is priority 3, is a real key area that we can actually look at a bit locally as well, in schools. And I know yourself, Caroline, are looking around schemes for that as well. So I think there's real opportunity here to, in alignment with the national programme, that we can do things locally as well. And I think also that priority 4 that we're going to look at too also has a lot of preventative aspects that we can look at from a wider determinants point of view. So yeah, I agree. That is an exciting opportunity that we have for this.
So priority 3 will deal largely around the prevention and the changing of the generational approach to drugs. Thank you, Sue. I'm going to ask Jonathan Gribben. You wanted to say something, Jonathan?
Yeah, thank you. Sue, perhaps in a moment, will be able to confirm whether or not your chief exec or her team were involved. I think you'll find that they're involved in the meeting on Monday. In terms of where the money is flowing to at the moment, the money coming to Nottinghamshire so far is very much prescribed by government. And you're quite right, in that sense, the money coming to us so far has some criteria around it about what it needs to be invested in. And yes, I look forward to other streams of funding coming through which can be properly deployed around some of the other streams. But I just wish to make sure that no members of the Health and Wellbeing Board imagine that money coming from government is somehow being taken by Nottinghamshire County Council Public Health for its purposes. We will be sustaining our current investment in this agenda. What's coming through to us from government largely will be to go, it's additional, it's additionality.
Councillor Wilmot.
Thank you, Chair. Yeah. What have I got to say? Substance misuse seems to be rising all over the areas at the moment, all over the country, and it brings misery to many households, as we all know. How do we combat the problem? It is going to be very, very difficult. While there is money to be made, it will be difficult to break the drug supply chains that are taking place at the moment. And to deliver a worldwide treatment and recovery system will be even harder, knowing that getting the users off the substance, which is so harmful to the system and so addictive, that's the big problem. It's so addictive. And it's going to be difficult because crime and drugs seem to be together the problem. It's a total problem, not just the drugs itself, it's the crime that it's involved with it. It's so connected, and the problem that rival gangs are causing by fighting each other is taking a lot of resources out that the police could use on other issues. I do realise that. What's the answer? Well, there's only one answer, but it'll never ever happen. The answer is stop the growing of the substances in these countries that actually, grow all these things, and that will unfortunately never happen because many of the countries survive on the sale of some of these products. Unfortunately, it's a most incredible situation, but that is the truth about the whole thing. Stamp on the distribution of these drugs by giving the police more powers. Is that a problem? I mean, are the police happy with their powers to combat drugs and alcohol misuse? Are they really happy with it? If not, they need to be saying so and talking to the government. They need more powers because it's all right scratching at the subject and just getting things done, but for every time we seem to collect or stop some of the problems, there's 3 others start. I'm just a bit concerned. But I do really welcome this establishment of this partnership. I must say it's absolutely brilliant. I'd like to drill down into the problems that we face on it. The County Council recently released figures that estimated that there were 175,600...
John, can I just interrupt you there, that the Joint Strategic Needs Assessment will be dealt with in a few minutes, and it will be going into all of those figures. I would like to say that there's an awful lot of stuff that isn't grown abroad that is actually
my final point is about the DARE project. If people probably recognise how well that did some years ago. I was on the council at the time, the DARE project. Yes. Now, I've had three schools ring me up and say, have you got any money? Because there's a system going to start that's like the DARE project. We haven't got the money to get involved in it, but we'd love to be able to do it. Yes. Now, the DARE project, it actually went into the schools from age 7 to 13 and really got things done. And I'm just wondering if there's any help can be got to get that sort of a project going again. Thank you.
Follows on nicely from Caroline Henry's point about the prevention, and you can't be going in to see people. A lot of it stopped with COVID, of course, didn't it? So, and some of it hasn't restarted. I've got Councillor Tideswell and Councillor Wheeler. Councillor Tideswell first.
Thank you, Chair. The DARE project was actually not age related. It's an American one. and it is not related to the schools age appropriately. Long problem. I am normally take the empiricistic way, but when it comes to actually supplies of recreational drugs, I prefer to take the nativistic way. It doesn't matter. It is the most easiest preventable way of making sure that youngsters and adults don't get hooked on it. And until we actually get this problem solved, we are going to be throwing more and more money at it and more projects at it. That is the basics. So I would like to say, I mentioned last time, Caroline, when this subject came up, we do really need to be on top of this one. I know how much pressure the police force are under, and that's enough. We'll carry on. Thank you.
Thank you for that point, Councillor Tideswell. Councillor Wheeler.
Thank you for the report. I just wanted to comment on something that I've not actually seen in this report, which relates to e-cigarettes. E-cigarettes are very concerning to me because they're actually a very fashionable item that young people are, increasingly using on a regular basis. They're highly addictive, got nicotine in them. They actually can cause damage to your lungs. There's been research done on that. And my other concern is that in terms of prevention and in terms of preventing young people going on to harder things, well, e-cigarettes, actually, you can use marijuana in e-cigarettes and other substances in e-cigarettes that are actually very, very harmful. So I was wondering, in terms of substance misuse prevention, what sort of things could be added in terms of looking at e-cigarettes as problematic for the youth of today, because smoking has reduced amongst young people, but conversely, e-cigarettes have grown massively, and a lot of companies are making huge profits from that. Thank you.
Yes, I mean, the Stop Smoking, Make Not Smoke Free was very clear that our policy is harm reduction. We know that e-cigarettes are 95+% safer to use than cigarettes. We know there's over 300 carcinogens in a typical cigarette. There is no carcinogens in nicotine.
My point is that e-cigarettes can be used for harder drugs. That's my point. My point being that young people are now finding ways to access harder drugs as a result of using those, because you can use marijuana within an e-cigarette.
And indeed, it's that sort of abuse that brought about EVALI, which is the acute vaping lung injury, and particularly the cases in California about adding things to e-cigarettes. So there is the potential for that, but from our point of view, it's the balance of harm reduction. If something is 90% less harmful than something else, it makes absolute uncontrovertible sense to follow that pathway. Councillor Jonathan Gribben.
Thank you, Chair. Yeah, and thank you for the question, Councillor Wheeler. And I suppose a reminder of a couple of things, and then a trailer for what might be coming along in a month or two. So it was just a month or two ago that the Health and Wellbeing Board held a workshop around Stop Smoking and looked at gave some consideration specifically to matters relating to e-cigarettes, the opportunity that they provide us as a support for people to quit, so taking Chair's lead there around harm reduction and the value potentially to Nottinghamshire in those terms. We also gave some attention, though, to some of the other things that would need to be put in place, for example, through trading standards, to make sure that e-cigarette products or products associated with e-cigarettes are properly sold to those who are properly entitled to buy them and not sold to children. The trailer I wanted to give was that that will be coming back, I think, to Health and Wellbeing Board in due course. Also within the County Council, if I can speak to that for a moment, it's also something that we're doing some work on within Nottinghamshire County Council, and with a view to coming up with some recommendations about how we might make e-cigarettes properly available to people as part of a quit aid. But that's still something we're working through giving proper attention to some of the considerations that you've identified. So watch this space, I think.
Thank you, Jonathan. Councillor Camilleri.
Thank you. It's very interesting because I'm the chairman of Life Skills, which was there. And just a bit of information, the Life Skills programme is real British. We left there probably 2 or 3 years ago, and we've done that. This system we have, 400,000 children have been through the DARE programme, and that's set up to educate children in life skills, not just about taking drugs, smoking, it's how they live their life. And it was evaluated by Trent University, which proved that it did make a difference. You're not going to change everybody's mind, but you're going to change some people's mind. And I think that education is number one. I agree with Councillor Wilmot. I think education, helping these children make choices when they're very young, because they don't get choices at home. And I think that education comes first. That we're like shutting the stable door when the horse has bolted. When there's an industry in drug rehabilitation, I think we ought to get education sorted out. And through the help of the PCC, Life Skills have done a great deal of work, and education is number one. Teach these kids to make choices, and perhaps they'll make the right choice. Thank you. Thank you.
Thank you indeed, Councillor Camilleri. We're actually going to move on now because the second paper is all about the same thing, about cannabis, about cocaine, about MDMA, about ketamine, about an enormous amount of the substances we abuse and the detail of the people specifically in Nottingham and the areas of Nottingham. So I'm going to move that we endorse the arrangements for Nottingham Combating Substance Misuse Partnership. I'm going to move it and if we can have a seconder, Councillor Camilleri. Councillor Camilleri, can we have a seconder for the paper? I'm moving it. Can you second it? Thanks for volunteering. All those in favour? Thank you. Very good. Unanimous. Right. Now, in order to satisfy all of the questions, indeed, Councillor Tideswell, probably the one that you've got coming forward, we have nothing less than a 100-page joint strategic needs assessment dealing with all aspects of drug abuse, drugs and alcohol within Nottinghamshire. It's an absolutely fascinating read. I would say to each and every one of you, if you're ever looking to research anything on Nottinghamshire, go on Nottinghamshire Insight, go on the Joint Strategic Needs Assessment page, and the 42 live Joint Strategic Needs give you more detail than would be for preparing for anything that you might be asked. And this was rejuvenated in June 2022, so this is bang up to date from 2018 or 2019. The statistics within it, as we'll hear shortly, are 170,000+ people with drug or alcohol problems in Nottinghamshire, and over 12,000 people with drug problems. The reality is that we hear a lot about the cocaines and the cannabis and the amphetamines, more recently the nitrous oxide and the laughing gases and the ecstasies and the opiates and the abuse of drugs. But in reality, the harmful effect of alcohol, be it criminal, be it social, be it domestic, be it occupational, be it health-wise, is far in excess, and that's why a lot of the work that we're actually doing is concentrating around alcohol itself. And that's why we're speaking so much about it today. For those of you who have read the 97 pages, I'm going to open questions. Okay, I'll open it to everybody. All right. If anybody has got anything to say about the Joint Strategic Needs Assessment, now is your chance to say it. I, for one, would be very keen to pass over to Tristan Snowden-Poole to give us a summary. Thank you. Over to you, Tristan.
Thank you, Chair. Afternoon, everyone. So this is an update on the key points of the latest substance misuse DSNA chapter, The chapter's already been approved and endorsed by the Substance Misuse Strategy Group, and we bring it here today to the Health and Wellbeing Board for approval. So similar to the 2018 chapter, we've combined drugs and alcohol into one chapter and adopted a life course approach to how we've written it. The reason for this is polydrug use is very common, and the root cause of substance misuse and dependency is usually similar, irrespective of the substance of choice. So we've updated the data where it's been possible to do so. We've included the influence and the impact of COVID on Nottinghamshire and on our local treatment services. We've looked at the implications to Nottinghamshire of the new national drug strategies, as Sue outlined, and we've revised the recommendations to reflect those national developments and local priorities. Can I have the next slide, please? Thank you. So what we know, what we do know is substance misuse is associated with a wide range of health and social issues, and dependency in particular is commonly associated with poor health and social outcomes and with antisocial and criminal activity. What we know about the causes of misusing substances and of dependency is highlighted in the report and the details in the chapter, so I don't intend going through this now. What I'd like to look at is what we estimate the scale of the issue to be in Nottinghamshire. So actual prevalence is difficult to establish, but we've attempted to synthetically model estimates around substances in Nottinghamshire. So we've estimated that there's at least in the region of 176,000 individuals who use substances, so drugs and or alcohol frequently, and who could benefit from some form of a substance misuse intervention. That's indicating at least 1 in 4 of the Nottinghamshire adult population. There are estimated to be around 13,000 who are dependent on substances. And it's worth noting, firstly, these are estimates, and secondly, they're likely to be underestimates because of the hidden nature of substance misuse. People don't disclose it necessarily when asked, and they don't necessarily come into contact with public sector services either. In terms of the scale of this issue, alcohol represents the greatest need. So there's just a couple of slides on alcohol. If I could move to the next one, please. Thank you. So it's estimated of this 176,000, that 160,000 of them, so the vast majority of those that are drinking at levels that could be harming their health, 91% of this figure. And for dependency of the estimated 13,000, around about 2/3, so 8,500 are alcohol dependent. If we look at that in terms of the impact on Nottinghamshire residents and on our local services, if we look at the next slide, please. There's lots of examples of the impact substance misuse has in Nottinghamshire in the JSNA. But just very briefly, as an example here, let's look at hospital admissions in relation to alcohol, because this is some of the most reliable data that we capture across the health and social care system. So for alcohol-specific hospital admissions, rates in Nottinghamshire, they are lower than the England average, but they are, when you break it down to district level, they're higher in Mansfield and Ashfield. And then if you look at alcohol-related hospital admissions, in Nottinghamshire, they're higher than the England average across all districts, except Bassett Law. They're higher for both males and females, and across all age groups, with more admission episodes in the age bracket 40 to 64, broken down to male and female, so females 40 to 64, and for male, mostly in the over 65s. Next slide, please. Thank you. If we look at our local treatment and support services, so the local authority and the Police and Crime Commissioner co-commission Change, Grow, Live, CGL, to deliver substance misuse treatment and support across all districts of Nottinghamshire. They've been delivering services since 2014 now, and they're responsible for the whole substance misuse pathway. So from when someone comes into service entry through to treatment exit. This is their website, and as you can see, they provide support for young people, for adults and their families. And for those who have dependency issues, they deliver and offer structured care plan treatment. So if we look at the next slide, if we just look at this dependent cohort for a second, so these are people who are dependent on substance misuse, and are seeking treatment with CGL. So 4,500 individuals are in structured treatment for drug and or alcohol dependency at any one time, and 2,400 are new presentations within that year, so new individuals coming into contact with the service. Across all substances and across the whole of the service, 20% exit drug and alcohol free, and that's broadly in line with national performance and with local authority comparator areas as well. And for those that successfully discharge, and also for those who are likely to be in treatment for some time, we monitor and we see improvements in physical health, mental health, and social circumstances, such as education, training and employment, housing situations, and self-disclosed overall quality of life. Next slide, please. So a quick note on the impact of COVID and what that might be telling us for the future. So in terms of drugs, drug usage levels didn't significantly change locally or nationally. But for alcohol, again, both nationally and locally, there was more drinking at home. Those who drank more, and referrals into alcohol treatment have increased and continue to increase. And individuals are presenting at a later stage of their drinking. So they're presenting to our local treatment services with more complex needs. Next slide, please. So a few key points on unmet needs. So the JSNA identifies that alcohol represents the greatest need, particularly post-pandemic. For those who are seeking support or treatment, we have good outcomes from the local treatment services, but there could be a stronger focus and a more coordinated approach to education and prevention around substance misuse. And with it being considered in the context of a broader risk-taking behaviour. Local partners could do more to reduce the supply of substances into communities. So an example of that would be utilising district licensing processes. So we could inform decisions regarding the concentration of licensed premises in any particular geographical area in the county. We're looking at improving and evaluating pathways for vulnerable individuals to make sure those pathways are now fit for purpose. And also, and in particular, that's for people with coexisting mental health problems and those going through the criminal justice system. But we also want to build on the excellent coordinated partnership work that took place during COVID and its lockdowns for those individuals who experience multiple disadvantages, such as substance misuse, mental health, homelessness, and domestic violence. And then another key area is, and this will be through the new Substance Misuse Partnership Board, improving the systematic collection of and sharing of data between partners to provide a clear overview and a basis for action to address substance misuse strategically across NOTs and across our systems. And then finally, next slide, please, in terms of recommendations. So there's 16 recommendations in the JSNA. They've been grouped into these 5 categories. Recommendations around governance, commissioning and service delivery, some alcohol-specific actions, prevention, early intervention, and then what we need to do around data across the system. And then final slide, if we're to draw your attention to a few key recommendations, we would say recommendations 1 and 2 builds on what Sue was mentioning earlier. These will provide the governance and the infrastructure for driving action on the majority of the recommendations that are in this JSNA. So establishing the Combating Substance Misuse Partnership Board and ensuring that recommendations are woven into the work streams of this group. And also making sure that its work aligns with the strategic priorities of the Health and Wellbeing Board, as well as other key boards such as the Safe Nottinghamshire Board, the Integrated Care Partnership, the Domestic Violence Board. And then recommendation 2, which is implementing locally the new National Drug Strategy. a range of tasks already underway in relation to this. So commissioning plans that have been submitted nationally, auditing locally against the newly released commissioning standards, health needs assessments of drug and alcohol across all 3 strands of the drug strategy, agreeing a local drug strategy, a substance misuse strategy, and of course ensuring that there's capacity in the system to deliver on the ambitions of the strategy locally. So that's just a brief overview of some of the key points that's in the refreshed GSNA, and we ask the board to approve the chapter. Thank you very much.
Thank you, Tristan. A very comprehensive report in terms of figures and the balance between the drug impacts and the alcohol impacts, etc. I'm going to throw it over to anybody who's got any questions. I've got Councillor Walters.
Yeah, a real quick point, I hope. Maybe you can answer this one, Dr. Doddy. Page 71 of 580, hic cough. Almost at the bottom of the page, there's a subject that entitled Enhance Harm Reduction Provision. And that's increase the availability, excuse my pronunciation, naloxone, piloting the use of Buvidal. Is that some kind of new methadone treatment or methadone treatment? Is it an opioid substitute or yes. Is it the silver bullet on the, you know?
It's not a bullet.
Oh, right.
No. It's Buvidal is something which I think it had a lot of success originally in the prisons of Scotland through COVID, when the contact with prisoners has been reduced to a maximum or a minimum amount, and they switched from an oral form of Subutex, which is called buprenorphine, and instead of doing it, they switched to something which was an injectable, and the injectable could be given every 7 days plus or minus 2 days, and that then became so successful in the prison that they rolled it out elsewhere, and that is now one of the things that we're trying to prioritise through our Change, Grow, Live clinics. I think it sounds amazing. The potential for Subutex and those drugs to be abused and not properly dissolved under the tongue, etc., particularly amongst prison type communities, was huge. I mean, I worked detoxing prisoners from alcohol and drugs at Nottingham Prison, and did this type of work, so I'm familiar with it. So that's what it is. It's not a new bullet, but it's a new approach to an existing bullet. Thank you, Councillor Walters. Tristan, did you have anything to add to that?
I'd just add to that yes, it's a longer acting opioid treatment. It's another treatment in our armoury for our treatment services, and we've started piloting it, and we're having early successes with it.
Fantastic. Any other? Councillor Wilmot.
Thank you, Chairman. Yes, obviously I welcome all this assessment. I think it will do some good in the end, but assessments and actually getting the policies through and actually action speaks louder than paperwork, actually, and there's no doubt about that. Apart from the cost of living crisis that we've got at the moment, substance misuse is the biggest single issue we face. There's no doubt about that. There are huge areas of Nottinghamshire that has a drug dealer on most street corners. In fact, drug dealers have replaced convenience stores in many areas, I'm sorry to say, because there's been so many shops shut down in that situation. In fact, despite the government rhetoric, there are less police officers, or there seems to be less police officers with full powers of arrest now than in 2010, when the government first got into power. And obviously this represents the biggest single failure in policy, and we're being let down. The police are being let down by the government. People are dying as a result, and no amount of assessments will change the fact that it is policing our way out of this problem that will solve it. County lines, drug dealing at the present time we know is rife, We have drug dealers opening, selling drugs. Our street smells of cannabis, and we have more people ill and sick from drug dependency than ever before. Do you agree, do everybody agree, that until we get more police on the beat, until people are stopped from drug dealing with impunity, we're just going around in circles? The other issue, of course, going to page 30, the unmet needs and service gaps. I'm astonished that there is no current systemic process for sharing existing data between partner agencies. After all these years, we're still not helping each other and putting out all the information so that we can fight this problem together. It's astonishing. Thank you, Chairman.
Thank you. It's always been a challenge and will continue to be the multiple potential presentations of drug and alcohol problems throughout the entirety of the system. People can be in the A&E department, people can present to the local GP, people can be arrested by the criminal justice system, people can present through domestic problems, people can be presenting through violence, etc. The multifaceted presentation of drugs and alcohol is indeed a challenge, and one of the challenges that part of the new partnership board will be seeking to resolve, that wherever you present, where there's a clear indication that this is drug or alcohol related, that there ought to be a way into the system in a preventative manner to identify and early intervene, and indeed also fit in with your previous idea of the prevention agenda as well, Councillor Wilmot. I'm going to actually go to Caroline Henry to give us the police point of view. There's no point in having the police and crime commissioner here if we can't make her answer some questions.
I've been bursting to get in, so thank you very much, Chair. The police cannot do this by ourselves.
No.
It has to be a partnership approach,
Yes.
which is why my police and crime plan was called Our Make Not Safe Plan. And there's 3 key priorities in there. And the first biggest one, and I'm a broken record with it, is about preventing.
Yeah.
Second, responding. Thirdly, supporting. And we have to get the preventative work done. While there's still a need, if there's a need for drugs, you know, if people are using them, we've got to have a much stronger message about the harm getting those drugs on our street is doing to people. And I know there's going to be a little bit of a focus on, I hate the word recreational drug users. It's not the right expression, but people who take just a few lines of coke at the weekend and think that's okay to do. There's going to be a real focus and target messaging from the government to try and stop that. So the preventative work is vital. I continue to support the Life Skills programme, and I'm really keen to do more education work in schools. The responding, I guarantee, there's nothing our police officers love doing more than locking up drug dealers, because we know drugs is an absolute scourge on our community. But also we have to get the supportive bit right, the supporting people to get off drugs, and supporting people as well, because sometimes people are self-medicating with drugs if they've got mental health, if they've got other issues. You know, there's early childhood experiences. It doesn't always happen, but we need to be really clear that we need to support people so they don't turn to drugs in the first place. So the police are very happy with the laws we've got at the moment. We don't feel we need a change in laws, but we do need a partnership approach to tackle this.
I don't think that there's probably anybody here who wouldn't support that view, and the element of making drug and alcohol a public health issue like they've done in Scotland. You only have to look at the festivals. I think it was Reading in Cheshire, where 2 people died from substance abuse over the last couple of weeks, and most recently a young 15-year-old died from inhaling nitrous oxide, also known as laughing gas. But she was an asthmatic, and I think it triggered an asthma attack and killed her. So the recreational drugs kill people. there's nothing recreational about that at all. On that, I'm going to ask Director Gribben his opinion on that.
Thank you, Chair. I was just going to mention that I certainly endorse what Commissioner Henry was saying in terms of the partnership approach that is needed to this. The purpose of the Joint Strategic Needs Assessment on this topic or on any other is to set out the evidence. The evidence actually indicates that there are a number of different ways in which we need to intervene. For sure, as Commissioner Henry has said, criminal justice aspects are an important part of that. And yes, making sure that the treatment and recovery part of that is important, and the prevention as well. And I think the opportunity, one of the opportunities of the new partnership board will be making some of the links, strengthening some of the links between some of those. And I'm looking forward to doing more work with Commissioner Henry's team to make sure that the links, particularly between some of the criminal justice pathways and the treatment pathways, are really strong. And that as and when funding becomes available that would assist us with this, that we can also make sure that we've got really strong arrangements in place in Nottinghamshire to support people who are in recovery and who are wanting to set about getting back to regularise their housing and employment and so on. So there's lots of work for us to do, and it will certainly involve the district and borough councils as well, Councillor Wilmot. And in the meantime, if there's further emphasis you want to give to it, I'd probably bring you back to the evidence, which is that the greatest burden of ill health in this subject area relates not to drugs, important and serious though that is, but to alcohol, and the opportunity that there is for licensing authorities to give attention to the intensity of retail outlets selling alcohol. So there's plenty that we can do between this whole partnership on this agenda overall. Thanks.
Thank you, Jonathan. I think I'm going to finish on that note. I'm going to move on, Councillor Wilmot. I'm sure you'll come in later on in a number of other areas. This is a partnership working at its best. I think it's very exciting. I think the Joint Strategic Needs Assessment is exceptionally comprehensive, and I certainly welcome it. And I'd like to thank Tristan Snowden-Poole for presenting that. I move the recommendation to approve the Substances Misuse Joint Strategic Needs Assessment as it is in Appendix 1. Seconded. All those in favour? Unanimous. Okay, I'm going to move on quickly to the next item on the agenda, and this one is targeted lung health screening programme. I had the joy of having a presentation by the two of the nurses who were actually involved in actually doing this just a few weeks ago, and it's one of those things that when you see the fact that it is targeting the most at-risk communities going into the Mansfields and the Ashfields where the greatest health equality exists to detect cancers at the very earliest stages where they can be successfully treated. It's no doubt a programme which we'll want to roll out elsewhere. I think City is next on its list of rollouts. But I'm going to go over to Simon Castle and the team. I can see Simon ready to roll. Simon, would you elucidate on the paper for us? Thanks.
Yeah, thank you, Chair, and thanks for inviting us back to update you on progress with the programme. As the title said, I'm Simon Castle. I'm Head of Cancer End of Life and Diagnostic Commissioning within the Integrated Care System. So next slide, please. So just a bit of context, a reminder of where this project is coming from. So the NHS long-term plan made it an ambition to diagnose 3/4 of cancers in early stage by 2028. Clearly early stage, as you say, Chair, leads to better outcomes for patients in terms of survival. However, for lung cancer, the 5-year survival rate in the UK is less than 13%. Prognosis for lung cancer is poor compared to a number of cancers, and I'll come on to that shortly. And so the national team have been prioritising lung cancer for a few years now, and particularly targeting interventions in those areas with greatest need, which is usually related to high smoking rates, deprivation, but also due to certain industries like mining leading to high rates of lung cancer. And so a national programme was launched, and Mansfield Ashfield was chosen as one of the areas to pilot this programme back in 2021. And we're excited to announce that it will be expanding into Nottingham City later this year, which I can come on to. So next slide, please. And just to emphasise why lung has been chosen for this programme of work, this is a table which looks at the proportion of cancers that are diagnosed early. So what we're trying to do is get all of these cancer points to as far to the right as possible. But as you can see, lung is highlighted there. It's one of the most common cancers in terms of incidence, but it has some of the poorest outcomes, and we're only achieving 25% of cancers diagnosed at an early stage currently. And so this programme is to try and target and improve that position. So next slide. So this is some of the early data that's coming from the national programme. I'll come on to the local numbers, but this just shows the breakdown of cancers that are being diagnosed through the national programme. And you'll see the positive outcome is that for the first 1,000 cancers that have been diagnosed, we're achieving 61% early diagnosis rate. Now, compared to the symptomatic population who present maybe to their GP or hospital, we only traditionally see around 15% diagnosed early in that stage 1 category. So we're seeing a real change, a reversal of the early diagnosis rates through this programme, which is really positive, and that's the aim. Next slide. So who's been invited? So anybody between the ages of 55 and 74 who've ever smoked, registered with the GP within Mansfield Ashfield have been invited, and we're nearly through the first round of screening for this population. Next slide. And just to outline the kind of process, the pathway that we have, patients are sent an invite letter with a set appointment. They initially have a virtual telephone triage to assess their risk factors, which are then built into an algorithm to identify their risk. Those that are deemed to be high risk, which is around 50% of the patients invited, then go on to have a physical lung health check, which includes a CT scan, but also smoking cessation advice for those that are still smoking. And then those reports are assessed by specialist radiologists and the results fed back to the patients. And then those where we've identified any significant pathology will then go into the hospital to have their treatment rapidly. Next. And as we say, this is about lung health, and we're trying to build in prevention to this. So it's not all about the treatment and diagnosis. Where possible, we're trying to reduce the very high smoking rates in Mansfield and Ashfield. So the service that's commissioned within by Nottingham Council, Nottinghamshire County Council, providing smoking cessation support on the unit. And around 30% of the patients that are coming through to have their scanner are still current smokers. So we've got a real targeted population that we're trying to intervene in terms of prevention. Next slide. And in terms of the model, we're making this a community-based pathway and service. So rather than going into hospital for scans, we're taking the service out into the population, making it as accessible as possible. So just some pictures there of the mobile van, the 2 vans that we have. One is a patient support unit, and then the actual CT scanner. So people can park literally right outside the unit, and it takes in total around 15 minutes to have the lung health check and the CT scan. So it's very accessible, and I'll come on to the locations that we've been in. Next slide. And then we've worked with local patients groups to really target our comms and engagement messages. We have targeted social media campaigns, radio, newspapers, and we've got our website. So we've worked very hard to make sure the uptake rate is as high as possible by being very targeted with our comms and engagement. And that's just some examples of the leaflets and the websites and patient stories that we've got for people that have already gone through the programme successfully. Next slide, please. So in terms of progress so far, we launched back in April 2021 as soon as we could. We've currently invited people from 21 of the GP practices in Mansfield and Ashfield. Services have been in, as I say, community locations in Warsop, Selston, Sutton and Ashfield, Kirkby and Ashfield, and we're currently at this civic centre in Mansfield, which is going well. But the patient feedback has been excellent in terms of access. We've tended to use supermarket car parks, leisure centres, council car parks, which are very visible, and just say on bus routes, easy to park at. We've sent out 22,000 invites, currently undertaken over 10,000 telephone assessments, nearly 4,000 CT scans completed, and we're following up, we've already followed up over 500 patients. We've had 30 cancers diagnosed so far, majority lung, but we've also identified breast and urology cancers. But we've got a considerable number of patients with ongoing diagnostics. So we anticipate those number of cancers to increase rapidly. But we're also finding lots of other pathology, as you would expect, both respiratory pathology, COPD, emphysema, pathology related to mining communities, but also lots of non-respiratory pathology as well, including liver disease, etc., etc. So cancer gets the kind of publicity, but we're finding lots of other pathology which needs treatment, and we're finding those early, which is positive. Next slide. So I've gone through that pretty quickly just to give time for questions. But as I say, it's the programme is working really well. We're just about finishing our first screen, and then we're going back round to all of those locations to complete the second round of screening for this population. Uptake rate has been around 70%, which is fantastic. It's one of the highest in the country, and that's definitely because of the community approach that we've taken in terms of where the locations have been. But anyway, I'll stop there and take any questions, Chair.
Thank you, Simon, for a very comprehensive report. I remember when originally hearing it, the fact that over 10,000 people had been contacted by telephone, which is quite amazing, but that 300 had been referred for local stop smoking cessation. I thought if I'm contacting 10,000 people who could be smokers, I'd be referring all of the 10,000, but you qualified that by saying that 30% of them are still smoking, which makes for 3,000. Yes. But 300 referrals still only represents 1 in 10 of the people who are contacted. Is there a simple explanation for that as to why we've only referred 300 out of the 3,000?
Yeah, so just to clarify, by default, all patients are referred through to the smoking cessation providers. That figure is the number of then accepted that offer. So maybe that should just be clarified. So by default, all of the smokers coming through the assessment by default are invited to see the smoking cessation advisors. That's the figure that are accepting that offer.
You mean turning up or to stop smoking, or just formally accepting it?
Formally accepted. So the smoking cessation team are actually based physically on the van. So it's based on every contact counts. While they're having their CT, they're invited to go and speak to the smoking cessation advisors. Unfortunately, not all do that. Some choose to decide not to. So we're getting about 30% of the smokers then decide to move on to take up that smoking cessation advice. Clearly, we'd like it to be higher, and we're trying everything we can to improve that rate.
Yeah, it just seems like a huge opportunity to intervene. Councillor Place.
Can I just say I was quite upset to receive a letter to say that I'd been a smoker, seeing as I've never smoked ever in my life. And I've lived in the same village all my life. Luckily, Brian, he came back to me and put me at rest. Because I was getting all upset thinking, oh, what's happened? You do, don't you?
You do.
And I think a lot of money might have been wasted sending out letters to people who've never smoked.
We'll have it minuted that Councillor Place has never smoked. How's that? Any other questions? Yes.
Looking at the main theme of the report, it's concentrated on smoking. But Simon referenced the mining industry, and I just wonder how much residual industrial health issues that presented themselves through this programme, which seems excellent to my mind. And I just wondered what effect, not just through the mining industry, but people's industrial health working process.
I'm sorry, Chair, the question isn't coming through clearly on the...
Can you hear me, Simon?
I can hear you, yes, but
Yeah,
question.
it's simply, I know this is a cancer screening programme, and you've reported back to us on cancer. You've reported back on lung cancer, urology cancers, etc. The question was incidental pathology, particularly coal miners, pneumoconiosis and complications of industrial activities. Are they recognised, are they referred on, or are they just by the by?
So just with respect, just a correction, it's not specifically a lung cancer screening programme. This is a lung health check programme. So you're absolutely right. It's not just cancer. So cancer gets the headlines, but actually most of the pathology that we're finding is non-cancer and other respiratory disease. We have a incidental findings protocol. So all of the other non-cancer pathology is then redirected into existing services, whether that be in primary care or secondary care, and it's rapidly assessed and they are followed up. So actually the vast majority of the pathology and diagnosis that we find is non-cancer. As you say, COPD, emphysema and other related, and we're finding lots of it, as you would expect. But I've just reported on the cancer, but I can assure you we're finding lots of other diagnoses and pathology.
Once again, Simon, this is a funded project and there's no guarantee that it'll be rolled out to the rest of the country. There's no guarantee it'll be rolled out to the rest of Nottinghamshire. It's a nationally funded project. Am I right in thinking that?
This programme is, yes, but it's the precursor to the next screening programme being lung. So that's currently going through the national screening committees for approval. It's highly likely that it will happen. But at the minute, this is based on pilots addressing those with greatest lung cancer incidence, so Mansfield, Ashfield, Nottingham City. But there is a very strong chance that it will become the new or the next national screening programme alongside breast, colorectal, cervical. Because as you can see from the numbers, we're totally switching the early diagnosis proportions around based on this programme. So the evidence base, both with this programme and from other screening programmes in Europe and America, the evidence base now is very, very strong to support this.
Fantastic, Jonathan. Any further questions? Councillor Wilmot.
Just a quick one, yeah. On all the issues we've talked about today, I don't feel we've talked about the big issue. Our strongest partner is the general public. In all these issues, without the help of the general public, we will be struggling to improve on anything. We have to get it over to the general public how much we need their help in stopping drugs, in looking at this lung health check programme, the early intervention, in being able to say, I've got something wrong with me. I know I have. I must go and see my GP or whatever. My question to the representative is, do patients know what to look for in cancer of the lungs or whatever? And is scans easily obtainable, or does everyone have to go through a GP?
Simon, do you want to answer that, or do you want me to answer it?
Well, I'll try and answer some of it. So it's partly the reason why lung cancer early diagnosis rates are poor is that the symptoms tend to be quite vague and non-specific. So obviously it can be coughing up blood, but the symptoms tend to be weight loss, loss of appetite, and unfortunately when that presents, the disease can be quite progressive. So that's almost why it's so important in for lung cancer that we have screening, because the symptoms are quite vague and non-specific, apart from the coughing up of blood, but that tends to be often, unfortunately, too late. So there's lots of publicity campaigns about, persistent cough and coughing up blood, etc. But and people need to present to their GP with those conditions, but we need something more targeted and specific to identify those cancers early. Chair, I don't know if you want to add to that, being a GP.
That's very comprehensive, Simon. Are you free to do any surgeries in the coming weeks?
About that, sir.
I'm just going to follow that up by Councillor Wilmot, saying that there are lots of parts of the body that, when diseased, have to get to a certain extent before they affect any activity. And the size of the lungs and your lung volume, etc., allows a lot of people to continue for a long, long time before they're incapacitated. Depending on what you do, if you were, say, a long-distance runner and your performance fell, you might pick things up quite easily. If you normally go home and sit and watch the TV, you could lose, 70-80% of your lung capacity, and you might not even notice it. So it is a slow process. Ovarian cancer is a classic. Pancreatic cancer is a classic. They're slow and very difficult, even with the best educational program in the world. And that's where screening comes in, because screening obviously is a far more effective way of picking things up before you even know you've got it. I'm going to go across to David Briggs, the Medical Director of the ICB. David.
Yeah, Simon, it might be worth just giving the current position on recovery of cancer referrals in Nottinghamshire, because compared to other systems in the Midlands, our recovery in terms of number of referrals is right up there at the top of the chart, isn't it? So we are encouraging and we are seeing a lot more patients with suspected cancer than our peers. So although there's work to do, and some of this work I think you've explained extremely eloquently today, Simon, so thank you for that. We're actually ahead of the game on this, which is good to hear.
Yes, you're right, David. We've as a system, we've done well in terms of finding what's deemed the missing cancers that didn't present during COVID. And so our referrals, urgent cancer referrals into our hospital systems, have been running now for a year at nearly 120% of what they were before COVID. So we're down to around 2% of the missing cancers now not being identified. At its peak of COVID, it was as high as 10 or 12% of those cancers missing. So but lung actually is slightly different in that that's recovered at a slower rate, and that's why the lung screening programme is even more important. That's partly because lung cancer and COVID kind of symptoms are quite similar, so I think there's been confusion around that. So, but overall for cancers, you're right. Yes, we've done, and the hospitals have done brilliantly in terms of meeting that extra demand that we've seen and treating all those patients.
So you're saying, Simon, we're within 2% of recovery back to the normal cancer detection rates that we might have had pre-COVID?
Oh, we've exceeded the detection rate. So we're diagnosing more cancers. It's in terms of the missing cancers that we didn't see coming through for about a year from the beginning of beginning of COVID. And so we're down to around 2% of those cancers now presented, but no, in terms of actual diagnosis numbers and treatment numbers, we're up at around 110, 115% of what it was before COVID. So we're seeing more patients and more cancers, and that's because of, we're catching up with those presentations.
I think that's quite remarkable. Thank you very much to Simon Castle for his presentation. I'm going to move the recommendation that the Health and Wellbeing Board considers promoting the targeted lung health check programme locally, and whether there are any actions in relation to the various issues outlined in the report. I move it. Have we got a seconder? Councillor Camilleri. All those in favour? Fantastic. Thank you very much, Simon.
Thank you, Chair.
Excellent. So we're going to move swiftly on now to item number 8. And item number 8 is the improvement statutorily required from the Health and Wellbeing Board, just as much as the physical side of things with joint strategic needs and a health strategy to improve the health and wellbeing of the people of Nottinghamshire. We are required to have a pharmaceutical assessment, check if pharmacy is indeed up to what we would require it to be demographically to meet the health needs of the people of Nottinghamshire. Clearly, there's been some vast potential building projects in Nottinghamshire, and some of which have already started. So continually demographics and needs are changing. And it's those that we're looking out for. Have people got sufficient pharmaceutical provision of service available to them? I was quite interested in the fact that of the 163 pharmacies, which there are, 7 of them are distance selling. So in the world that we live in, the Amazon world, etc., the fact that 7 of them are surviving as distance selling compared to the 163, that the provision of services in pharmacy itself is obviously meeting a need in a physical point of view. I'm going to go over for more detail on it to Sue Foley. Are you there, Sue?
Yes, I am. Thank you, Chair. So it's just going to be a short presentation on this very large pharmaceutical needs assessment. Here we are. So, as the Chair has just said, it is a statutory duty of the Health and Wellbeing Board to assess needs for pharmaceutical service and publish a statement of its assessment by October. So we're in under the wire, which is good. The pharmaceutical needs assessment, as Joe said, does look at the demographics and health needs of the population and how they'll change within its 3-year time frame. But also, yes, it does look at what structural changes there are going to be in terms of roads, in terms of buildings, in terms of pharmacies themselves, either closing or opening, and how that's going to affect the provision in the 3-year time frame. So that's what it looks like. So the current provision that it looks at is the provision of pharmaceutical services by pharmacies, dispensing appliance contractors, those who just dispense appliances rather than drugs, dispensing doctors, so GPs who have a dispensing facility, both within and outside of Nottinghamshire, because obviously some people maybe just across the border may be more of a convenient pharmacy to go to than within Nottinghamshire. So it's been analysed and mapped, so any current or future gaps can be identified. So the gaps are then articulated as a need for a particular service or range of services, or as improvements or better access that's required for pharmaceutical services or range of services. So what do we mean by pharmaceutical services? So they're defined as essential and advanced services provided by those pharmacies and dispensing appliance contractors, any enhanced services commissioned from pharmacies by NHS England, so it can be a national thing that pharmacies are commissioned by, and also dispensing services provided by GP practices. Now, essential services, there are 7 of them, the most obvious being the ability to dispense drugs and appliances under prescription. And for advanced services, there are 8 of those, 3 of which are, I'll give some examples. So flu vaccinations is one, the smoking cessation service from a pharmacy is another, and also hypertension case finding as well. So if you go into the pharmacy and have your blood pressure taken, that's deemed an advanced pharmaceutical services. So that's an idea of what they provide and what the pharmaceutical needs assessment looks at. So in its development, we actually had an outside contractor that were commissioned to conduct and write the pharmaceutical needs assessment. Unfortunately, we couldn't get a representative to present today, because of which was a shame, because they would know obviously more about the conduct of actually developing the pharmaceutical needs assessment. But there was a steering group which was highly involved in the process. It had representatives from, as they were, the clinical commissioning groups from Bassett Law and Nottingham and Nottinghamshire, NHS England, the Nottinghamshire Local Pharmaceutical Committee, and the Local Medical Committee as well. And the Nottinghamshire City Pharmaceutical Needs Assessment was done at the same time by the same commissioner, which was good, because then they could have that linkage between the city and the whole county as well. So there was a formal 60-day consultation on the draft, and the views on the provision of pharmacies was actually sought from the public as well. So we did get a public view about what people think about pharmacies in Nottinghamshire. So after the 60-day consultation, there were no concerns raised regarding non-compliance of regulatory requirements, and no pharmaceutical provision have been missed, and the conclusions were agreed with. And the draft was sent around the Health and Wellbeing Board members, which I'm sure you all read cover to cover, but thank you to those who did provide feedback on the pharmaceutical needs assessment. So in terms of the conclusions that it came to, as the Chair just said, there are 163 pharmacies open across Nottinghamshire. We've got 22 open for the 100 hours per week, which is the pharmacies that are open outside normal working hours, which of course is really beneficial for the community who may not be able to get there during the normal working day. As Chair said, 7 are distance selling premises, so these are better known as internet pharmacies. The pharmacies provide essential services remotely to people who actually can be anywhere in England, because they are an internet pharmacy. 6 dispensing appliance contractors within Nottinghamshire, so these are ones who just dispense appliances rather than drugs, and there are 12 GP practices who are eligible to dispense to their own patients, which is good. Those dispensing appliance contractors, they may only dispense valid NHS prescriptions for appliances such as catheter and stoma bags. They also tend to provide pharmaceutical services remotely as well, so it tends to be delivered to people's homes rather than people coming actually into any shop. So, just to say, the main conclusion is that there are currently, and that's the buzzword here, currently no gaps in the provision of pharmaceutical services. Taking into account the predicted growth in the population, it's anticipated that the current spread of pharmacies, dispensing appliance contractors and dispensing practices, both in the county and the neighbouring areas that were looked at, will be able to meet any increase in demand. And that the majority of the population do live within a 20-minute drive of one of the 100-hour pharmacies, which was a big thing that we're going to make sure that people can actually access pharmacies within the 100-hour period, which is obviously essential for access for the entire population. The one thing to point out, though, is Retford, and sorry to highlight Retford, but it's they just identified one potential future need for provision of essential services, because there's a potential gap on Sundays in Retford between the hours of 10 and 4 o'clock. because one of the 100-hour pharmacies, I believe, is closing then, so that could be a permanent loss of core opening hours of Sundays in Retford. So that was the only area that was an area of concern in the future. So obviously we're going to be looking at that, and is there a way that we can plug that gap that we found in terms of opening hours of pharmacies in Retford on a Sunday. But that was the only future gap that was identified. And so that's the finish. Any questions?
You mean you've covered all 400 pages in that report? Thank you very much, Sue. That was very comprehensive. I think those of us who look at chemists tend to think of them sometimes as one of the great underutilised assets within the NHS, and many of us have been involved in programs with chemists whereby the patient can ring the GP surgery, and then the GP surgery can refer them to the pharmacy, who would then have 5 or 6 appointments that they could be booked into for the pharmacist to carry out that work and look after them. There's also been many projects with regards to minor illness treatment, from head lice with Pharmacy First to simple treatments for simple conditions like hay fever, etc. So there's been lots and lots of projects which I'm sure that some of us are aware of, but we've never really reached into the pharmacies in a meaningful way to offload the burden and the considerable challenge that's coming down the line towards us. And perhaps, Sue, that may be something that we look towards in the next pharmaceutical assessment, whether or not something needs to be built in on a more concrete basis. The last time we did this, it wouldn't surprise me if it was Councillor Wilmot, but somebody did mention the charges for nomads and deliveries, that nomads are card-like systems which chemists deliver to elderly and confused individuals so that they have Monday to Friday on it. And it became a vogue for chemists to charge a £5 for delivery, whereas previous it was free. I think Boots were one of them. I think they subsequently withdrew it. Whereas we welcome the report, it's very much a status quo support to it, as opposed to anything mind or earth-shattering in terms of what is going to deliver over those 163 pharmacies. We'd like to turn them into mini surgeries in an ideal world. David, would you like to come in on any of those points?
Yeah, great piece of work, thank you. As actually all of the papers have been excellent, so thank you for that. So there's a couple of things happening. Firstly, the commissioning of pharmacy, optometry and dentistry is moving to the ICB over the next few months, all being well, as long as we can demonstrate we're capable of doing it, which I'm sure we will.
Sorry, Dave, just repeat that. I didn't catch what's moving to the ICB?
Pharmacy, optometry and dentistry is going to be moving from a directly commissioned NHS England provision to an ICB commissioned service. And as part of that move, we want to work with, obviously, as a partnership about what the potential benefits of the wider primary care offer to our citizens are. So the first stage of that, which you will have seen, is a draft of a general practice strategy. The second phase will be looking at how our citizens can benefit from enhancements to dental, optometry and pharmacy services. So not started that piece of work yet, but obviously want to work with colleagues in Health and Wellbeing Board and colleagues in Public Health about how, when we take over the formal commissioning responsibilities, what we can do about improving access, improving the type of services, and most importantly, improving outcomes for our citizens, which I think we've got a brilliant opportunity to do with that more local commissioning of services.
Thanks, David. There's no doubt that expanding the platform of the provision of care is part of the solution to the huge demand, etc. I think that's very exciting. Look forward to it. Excellent. So with that, there is only a simple recommendation, and that's to approve the Joint Pharmaceutical Needs Assessment 2022 to 2025. This is a 3 years. So David, you've got 3 years to get it sorted. I'd like to put that forward. Have I got a seconder? All those in favour? Okay, excellent. So that's the pharmaceutical. Thank you very much, Sue.
Thank you very much, everyone. Thank you.
Now, I'm just going to try and move past those 400 pages. And we're now moving on to item number 9. Item number 9, I've always found very fascinating and very interesting, which is the Better Care Fund. The Better Care Fund, in my view, was the precursor of the ICS. And indeed, in another world, it could have been expanded up to such a size that it would have been the ICS. It started back in 2013, and it was the first opportunity that the NHS had to spend money outside the NHS because it was prescribed money that had to be spent within it. And this allowed for the development of joint working between social care, local government and the NHS through a single pooled budget. That budget currently around 100 million, and nationally billions and billions have been moved through various Section 75 agreements, etc. So it was really a way, and this is very important for you, David, it's really a way of shifting money from the NHS into social care and community services for the benefit of the people, the communities and healthcare systems. And I think that is the salvation of the future, that social care represents the only way of relieving pressure on ambulances, on hospitals, on GPs, etc. And the expansion of things like Better Care Fund and the sheer philosophy behind that movement of monies into communities for people is extraordinarily important. So that's the type of excitement I get when I look at the Better Care Fund. It's not necessarily always shared by other people, but I'll pass over to Melanie Williams in the hope that she shares some of it. Oh.
Yep, I'm over here, John. Hello.
You're very welcome, Melanie. Carry on.
Thank you, John. And just to add on, there is an element which is about the NHS passing money to local authorities. There's also an element where we receive direct funding from the Department of Health for social care burdens, not least Care Act reforms from 9 years ago. So it's also a funding mechanism direct from government as well. So just to sort of make that clear to everybody. What is also very interesting around the Better Care Fund is the fact that we have to complete templates that we submit to NHS England, and we often have to do that in a timeline where we can't get the board's permission. So those of you that have been on the board for many years will know that we often get retrospective permission from the board. So an element of this report is asking you to endorse one of those templates. In the guidance, we have to get permission, but clearly we can't ask for permission for something we've already done. I know that some people do that often, but in this occasion, that wouldn't be correct governance. So all we can do is ask you to endorse that, and a decision was made by myself, Amanda Sullivan, and John, Councillor Doddy himself on that template. So that's one of the purposes of the report. The second one is to provide a really brief update on some collaborative commissioning work in the integrated care system. So this is part of the early work before we had the integrated care board to try and establish joint commissioning functions. So there's a number of areas we're looking at. So we have a partnership arrangement around learning disability and autism, for example, and that's all ages, it includes adults and children. We have integrated arrangements for children's commissioning led by Jonathan as Director of Public Health. And we also have arrangements that we're hoping to build and develop around mental health and care market management. So there's a brief update on paragraphs 12 to 14 about the progress of that group in developing these arrangements. Collaboration is the new word at the moment rather than joint. So some of you will be familiar with joint commissioning. It's now collaborative commissioning. The last thing to do, and this relates to that piece of funding that is protected for adult social care within the Better Care Fund and funding of reform. So I'm asking for approval to use some of that reserves to progress adult social care reform. So many of you are aware we're facing 8 pieces of adult social care reform currently, and I'm asking to use some of the reserves that we have in the Protecting Adult Social Care budget to invest in us progressing that reform, because at this moment we don't have any direct funding from the Department of Health for the reform burdens being placed upon us. So thank you, Councillor Dodding.
Yes, I mean the social care system is under enormous strain from costs, from utility costs, from staffing crises, maintaining workforces, and of course it's the beating heart. It's what allows early discharges, it's what unblocks bed blocking, it's what allows people to be cared for in secure settings, so there's less 999 calls. It unblocks A&E departments and provides independent living for people in their own communities. It is the holy grail of care going forward. Yes, I fully support that, Melanie. Anybody got any comments to make with regard to the Better Care Fund? Councillor Tideswell.
And just to put the book straight, Health Service has been collaborating with Social Services actually since 1975 when they started closing down the institutional, psychiatric and also people with learning difficulties when they started moving them all into the community.
Yes, yeah, a long time ago. It was Eunuch Powell in the late 1960s who started, as when he was then the Health Secretary, the original closures of the old asylums and the movement into the communities. Anybody else got any particular comments? Yes.
Yeah, when we use the word reform, using reserves to finance reform, what exactly does that reform mean? Is it more emphasis on the cold face, you might say, or is it just reforming processes?
Melanie Williams.
Do bear with me now, because this won't be a short answer, but you did ask the question. So adult social care reform has 8 elements. Some of it is about reforming frontline service models, but that's the smallest piece of the reform. So there's a document which is currently a green paper called People at the Heart of Care, and that looks at new service models such as using information, advice and guidance, better use of digital, increasing the use of the Disabled Facilities Grant that sits within our district and borough council partners, increasing accommodation-based support, again led by our district and borough council partners. So there's that piece. The piece that we particularly need to focus on as a county council is the charging reform. So this is the bit about how people pay for their adult social care, because adult social care is not free at the point of delivery. So there's a whole charging reform which places another sort of, I suppose, another 50% of people within the local authorities' support because of their assets. There's the second piece of urgent reform, which is about the fair cost of care. So that's about the price that local authorities and individuals pay for their care. And then the other piece is about assurance. So from March 2023, adult social care will be subject to inspection by the Care Quality Commission. The other aspects of reform will have separate money for the burden. So the reform to the Mental Health Act, and that's a legal reform rather than a frontline delivery reform, and the Liberty Protection Safeguards, which although is a legal reform for adult social care because we're in a regulated environment, impacts greatly on our practice. But again, that will have separate funding. The purpose is here, it's about our readiness to deal with all of that reform and managing that degree of change, if that's helpful. I know it's highly technical. We did take a paper through to Cabinet, to Councillor Carlton, took one to County Council with Cabinet member, Matt Barney, on adult social care reform. And so I would suggest having a look at that paper, because what we try to do is to simplify the changes in a very easy language, because it's highly technical, it's really difficult to explain. I'm not deliberately trying to avoid the question.
Melanie, can I just follow up on a point of clarity with regards to that particular paper? Anybody familiar with rest homes and nursing homes knows that there's 2 standards of charge. There's the money if you go in and you're being paid for by the county council, which might be, £750 a week. But if you go in as a private individual, you'll be charged £1,000 a week. So there's always been a disparity in charge between private funders and what the social care can afford to pay those homes. when we're looking, and it talks about the various monies to breach the gap, are we looking at bringing down what the private person pays? Are we looking at bringing up what the county council pays? Are we looking to get rid of it, meet in the middle? What's the strategy?
So we'll be taking a paper to this on adult social care and public health select committee next week. So if anybody wants to tune in and have a very detailed explanation, you can watch this space and watch select committee, everybody else. But effectively it's an equalising. So in Nottinghamshire, we're expecting that it would mean that we pay less for some of our provision because we're already paying above the fair cost of care. But in other areas where there's more affluence, people will start to be paying less. So it doesn't have an equal impact across the country. It doesn't have an equal impact on people. They have what they call a median. So some fees will come down, some will go up. So some providers will gain, some providers will lose, some councils will gain, some councils will lose. It's, like I say, it's highly complicated. But the idea is it's equality, so everyone pays a similar rate.
A meeting not to be missed, Melanie, I can say. Any further questions?
Further comment on that and explain the reason why I asked the question.
Yes.
That we don't sort of use money that's lost in, for want of a better phrase, bureaucracy, and it don't get down to people that really need, the people that are suffering, you know, the elderly and the vulnerable that need that, and that's the explanation for asking the question.
I think it's a very penetrating question. I think it was well asked, well answered, and is very interesting going forward. I think it seems to me like all of the money is going directly into the people providing the care and the people needing the care, which is what you'd like to see. But yeah, excellent question. I'm very pleased you answered it. I'm going to move forward with something very simple, which is just the recommendations which are to endorse the Better Care Fund for the year end 27th of May 2022 and to approve the use of the Better Care Fund reserves to progress the social care reforms to March 2023. I'm going to put that forward. Have we got a seconder? Second, all those in favour? Passed. Okay, I've got 5 minutes till 4 o'clock. Councillor Wilmot said it couldn't be done. I'd like to prove Councillor Wilmot wrong. It could be done with a minute to spare. It could be a minute to spare. So it's the work programme going forward. Those of you who was at the Smoke-Free Nottingham will have noted that the workshops are dynamic. The workshops are very involving of all those people that go to them, and they draw you in and they make you feel part of the type of strategy that you're trying to deliver, and I find them addictive. I really, really enjoy those workshops. The next one, is it a workshop that's up next, Melanie? Bryony. So there is a workshop coming up. When's it coming up?
It is coming up on the 12th of October, so it will be a hybrid. So the first section will be a formal board meeting where we'll be discussing the outcomes of the workshop on tobacco, and then we'll move forward into a workshop looking at our next priority for the health and wellbeing strategy, which is homelessness. Homelessness,
and the following meeting looks at the impact of domestic abuse and special educational needs and disabilities. And that will be on the 7th of December. So with that in mind, I'd like to thank you all for attending here today. I think it's been an extraordinary afternoon, and I look forward to seeing you at the workshop. Thank you very much indeed. Thank you.